Well, welcome again to another in that series at Mayo Clinic of the interviews with the experts. It's me, Malcolm Bell, your studio host for today. And I'm joined again by my colleague, Dr. Mackram Eleid, who's one of our structural interventionalists here in our Cath lab with a particular interest in pretty much all of the cardiac valves. So welcome again, Mac. At the last episode, we had a good discussion about TAVR in the younger patients. So we're going to switch to a different valve, and it's the tricuspid valve. So we're going to be talking about tricuspid valve replacement and repairs that are transcatheter rather than surgical. And maybe I'll just start off, we often say, this is the forgotten valve, but we've been talking about it a lot, well, quite a lot in the last few years. I don't think it's any longer sort of forgotten, and there's a lot of advances there. And all I remember about the tricuspid valve when I was doing my training is in an older patient with a bad tricuspid valve, that the surgical outcome in replacing or particularly replacing that valve, but even repairing that valve was not very good. And these are very, very high risk patients, and even if they've got good LV function. So we're here to talk about transcatheter interventions of the tricuspid valve, and maybe we'll just start off asking you what is the current threshold for considering a transcatheter tricuspid valve intervention, whether it's replacement or repair.
Well, thank you for the invitation, Malcolm. It's great to be here, especially talking about this really exciting field where there's so much new data emerging.
Yeah, in fact, I should have added that this is a particular area of your interest here. That's you're really focused on these new developments. So we've really got the right person talking with us today. But please go ahead.
Well, yeah, I think the threshold for treatment is currently we are treating patients who are symptomatic with heart failure symptoms who have severe or more tricuspid regurgitation. Recently, we've increased the grading of tricuspid regurgitation, seeing how much the right heart can enlarge and have even torrential TR, which is more than severe. So we typically want to show that the patient is symptomatic from the TR. So in many cases, we will do a right heart cath, potentially with exercise, to show that they have a cardiac output limitation to exercise, and also to show that the right-sided pressures increase even to a more significant degree than the left-sided pressures. Now, most of these patients have HFpEF as well, so they should be on medical therapy with ideally an SGLT2 inhibitor if they can tolerate that, if there's no contraindications, and then also some sort of diuretic. Although that's changing, we're still seeing over time whether is a diuretic really a prerequisite to treat someone with TRs, since it's just managing the congestive aspect of the symptoms rather than the low output.
Yeah. So, I mean, you talked about hemodynamics, and maybe an obvious question may be, particularly when talking about a threshold for intervention, is what are you looking for in even just the resting hemodynamics in terms of is there a pulmonary artery pressure that would make this prohibitive? Is there a right ventricular end diastolic pressure that would be prohibitive? I mean, do we know? Can you give us an idea of what you're looking for there and what those numbers might be that would deter you from offering a transcatheter intervention? And these are the cases, of course, that the surgeons do not want to touch.
Right. I mean, I can tell you what we have excluded historically and in clinical trials, but it doesn't necessarily tell us what is the limit. What are the actual limits or the boundaries that you could still successfully treat someone. So pulmonary hypertension. Now, most TR patients have mild pulmonary hypertension, group 2 from left heart disease. And if you look at the large population, they have secondary TR. Of course, there's exceptions to that, but we want to exclude precapillary pulmonary hypertension with a high fixed pulmonary vascular resistance of 5 or more Woods units. That's been our traditional cutoff, especially for valve replacement, because the concern is doing a replacement is a much bigger load on the right ventricle in terms of increased afterload. We abolish all of the TR with a valve replacement. And so there's a greater risk of RV dysfunction or RV failure. So that's one of the things we look at. And RVDP, we don't have a specific cutoff, but we look a lot at the echo strain and the echo measurements like TAPC, for instance, and we have cutoffs for that. Anything that's severe RV dysfunction, we will really think twice about intervening on the tricuspid valve.
Okay. So maybe just a few words on the tricuspid valve repair. I mean, how do you repair a tricuspid valve in with a transcatheter approach, and what sort of results are you seeing there?
Yes, the main option has been edge-to-edge repair, which is not only an alveoli stitch because it also has an annuloplasty effect. Because with the clip devices that we use, we're not only doing application of the leaflets, but it's also kind of pulling in the RV free wall towards the septum. So we get a little bit of an annuloplasty effect in addition to the application of the leaflets. So we have two devices that are being used. One is FDA approved, the TriClip device. The other one is still in trial phase. But by far, the TriClip has been the most common intervention done on the tricuspid valve worldwide. And typically, we're seeing a 2-grade reduction in tricuspid regurgitation. So the majority of patients will have moderate residual TR if you look at the large population. And most of these patients have secondary TR due to annular dilatation and some component of ventricular enlargement and dysfunction.
And obviously, a lot of these patients, well, probably most of them, are going to have symptoms of fatigue and right heart failure and edema. Does that improve? And if so, for how long?
Yeah, that's one of the questions is how long is this going? But we do see a nice effect in the randomized trials, the Triluminate pivotal trial randomized between TriClip and medical therapy. And there was about an 18 to 20 point improvement in the score, the Kansas City Cardiomyopathy Quality of Life score, which is a pretty large improvement in quality of life. And that was sustained to 1 year. And we have other real world data from Europe as well that look 2 and 3 years out that are showing sustained improvements in quality of life. But there hasn't been improvements in survival or heart failure hospitalizations that have been definitively shown yet from tricuspid intervention. That's one of the counterpoints from some who have concerns about whether there could be some placebo effect there in quality of life.
It's important because a lot of these patients are really quite incapacitated, aren't they? So that's good. So now let's turn our attention to tricuspid valve replacement. When would you consider inserting a tricuspid valve?
It's a very similar scenario, and we're seeing more and more that patients have both options. And so when we see our patients in clinic, we do the testing for both so we can consider them for any of the available treatments. So we have one FDA-approved tricuspid valve replacement device, and then many novel devices that are being studied in early feasibility phase. So we can consider them for any of those options. But as far as the ones who are better served with replacement are typically patients who have larger gaps. We know that that's one of the predictors. If there's a larger leaflet gap, that's harder to get a good result with edge-to-edge repair. Also, more leaflet tethering, moderate to severe RV dysfunction is another factor that would make them more likely to have residual TR. So those are just a few of the things, but also lead-induced TR where you can't remove the lead or you don't want to remove the lead.
Talking about a pacing lead.
Yes. Yeah, exactly.
Yeah. So from the procedural standpoint, what would be the success rate that you're seeing now, and what sort of complication rate would you see?
The success rate is high for in terms of being able to implant devices, 98, 99%. With replacement, we're seeing that over 95% of patients have mild or less TR. So it is more TR reduction with a replacement valve. And the cost of that is there's a higher risk of needing a new pacemaker. Patients who don't have a pacemaker with the Evoque valve, it's up to 25% risk of needing a pacemaker. Then there is also some risk of acute RV dysfunction causing some hemodynamic instability, and that's been reported in up to 8% of patients. And most of
Is
the
that
time
something that's transient and can be managed and they recover?
exactly. Yes, in our experience, that's been transient and everyone can recover from it, although you can see reports that are suggesting otherwise. So that's something we need to study more.
You mentioned about the pacemaker leads, and obviously some of these patients it would be that tricuspid valve regurgitation may be related to the pacing lead has been there for a long time. How do you typically manage that? And if the patient did require pacing, um, I assume that you're probably starting to think about leadless pacemakers in some of these patients.
Yes, if a patient has shown that they need a pacemaker before considering a tricuspid intervention, we definitely prefer that they have a leadless pacemaker placed in advance. So that is a nice option to have. In the ones who need it acutely after the replacement, we have three options. We can either do a leadless or we can do a coronary sinus lead if possible, which sometimes that can be a challenge. The device can sit a little bit more into the atrium, or we can even do a transvalvular lead. We haven't seen that that causes prosthetic leaflet dysfunction um, in most cases.
Mark, when we compare this to TAVR, where you're putting it into sort of a calcified valve and annulus, and but you're probably not seeing that with the tricuspid valve, of course. It is wide open. You don't. I don't know how much calcium you come across there. Does this present particular challenges in terms of the type of valve that you're going to put in and sort of the mechanism of making sure that it's there placed securely?
Absolutely. No, you're right, Malcolm. We hardly ever see calcification on the tricuspid valve. We never see it on the annulus, and we don't see it on the valve either. So it's totally different, as you mentioned. Then we have to have a mechanism of more active anchoring. So the Evoque valve has 9 anchors that scoop under the leaflets. That's the primary mechanism. But then there is also some annular and RV basal oversizing. But each valve that is being studied has a totally different anchoring mechanism. So sometimes if we don't have adequate leaflets for anchoring, they're either plastered by whatever disease process is going on or a large flail, then a different anchoring mechanism is more useful there that grabs onto the annulus or anchors into the RV outflow tract.
My final question then is just about durability. And how much follow-up do we have on these patients, particularly from the randomized trials? And what trials are needed going forward?
Yes, I think the durability still needs to be answered. We know we can do valve and valve in these tricuspid bioprostheses that we're placing. We know that after edge-to-edge repair, if we get recurrent TR, we can actually lacerate one of the attachments of the clip and still put a valve inside in some cases. So now we even have a way to do a transcatheter replacement after an edge-to-edge repair, which previously wasn't an option. But we do have some 5-year data on edge-to-edge repair that shows good durability. So I think so far it's looking good durability. And then what we need trials that compare to placebo to help address some of the questions that have arisen about why we're not seeing other endpoints. We need longer follow-up. And then we're going to have pivotal head-to-head trials these will be industry sponsored between new valves comparing to Evoque. So that'll be nice to have that. We also have the Class 2 TR randomized trial, the medical therapy coming out this year. That should be presented hopefully at ACC this year. So we'll look forward to that.
Okay. Well, we'll stay tuned for all of those results. And I think that this is obviously a new area. It's relatively early, but it seems to be advancing really quite quickly. There's a lot of these patients who have this condition. And you and your colleagues, are doing a phenomenal job. But we actually haven't mentioned our imaging colleagues as well, to play such an important role, pre-procedure and during the procedure. And So I think we have to pay credit to them as well. So, Mac, thanks again, for sharing your experience in this. I know that this is one of your this is one of your top interests at the moment, is really trying to perfect this, and wish you all the very best with that. So, with that, I'd like to thank you for joining us today.
Thank you, Malcolm. And I couldn't agree with you more that our imaging colleagues none of this would be possible without the expert imaging that is provided by both, our TEE echo imagers, and also cardiac radiology too, which we're using very intensely for these procedures.
Well, thank you, Mac. And again, thank you to our listeners for joining us, and I look forward to seeing you in future podcasts.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Mark Moline, Wound Clinic Director of the Cardiovascular Center at Mayo Clinic in Rochester, Minnesota. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducationmayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses, all created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.